Well, hey guys, out of respect for time, I'll get started if that's okay with y'all. Cool. I want to just take a moment to first off thank you all for taking the time to come here today, come to SAEM, support these lectures, and support all the research that everyone is generating. The title of this lecture, come on in, guys, we're just getting started a little early. Come on in. The title of this lecture is Guestimates, Estimates, and Survival Curves. Harnessing Science to Inform ED Prognosis for Seriously Ill Patients. I'd like to take a moment to introduce our group. My name is Satish Ganaga. I am a emergency medicine physician based out of Henry Ford Health and Michigan State University Health Sciences. I'm also the SAEM Palliative Medicine Interest Group Chair. And I want to take a moment to introduce my esteemed colleagues. I'm going to let them do it. I'm going to start from the far right, Dr. Naomi George.
Hey everyone, Naomi George, University of New Mexico. I'm a EM critical care physician and implementation scientist, and most of my research has been in this palliative care serious illness space. So there you go. Comment.
Pleasure to see everyone. I'm Reese Mowbray. I am a research methodologist. I work with Parade. My capacity here is more as a research methodologist, so I specialize in prediction and prognostic modeling, clinical decision rules. I work with tripod and other guidelines to help support those efforts. Clinically, I was an emergency nurse for about 10 years, and most of my personal research looks at building prognostic models for geriatric screening and assessment in the emergency room.
I'm Justin Bruton. I'm an emergency medicine and palliative care doctor in Winston-Salem, North Carolina with Wake Forest. And I've done some work with prognostication modeling as well, and primarily work on primary palliative care education and EM residency. And I'm also our fellowship director for hospice and palliative medicine.
I'm Laura Davenport. I'm an APD at Allegheny General in Pittsburgh. I do more of my research is in medical education. I'm working to bring more ideas like this to the residency person.
And so I think what you can see right off the bat, we try to put together a pretty diverse panel with a lot of EM background, but also touching on that crit care aspect, the palliative care aspect, and even the science and methodology that goes behind building some of these prognostication tools. Our learning objectives for today is we want to discuss the role of prognostication in the ED. I want to make sure that everyone in this room is familiar with the four common types of death trajectories to kind of add a framework for this discussion and make sure that you're comfortable recognizing them and teaching your residents and fellows how to recognize them. We want to talk about harnessing the prognostication literature that exists within emergency medicine. Come on in, guys, please. Also want to try to provide some tips to manage emotionally charged or difficult conversations with both patients and families with serious illness. We want to talk about prognosticating modeling literature and then review some of those models. And I'm actually going to start out here with the big why. I think in my clinical experience, both as an educator and administrator, you really can't create practice change amongst experienced EM physicians, even less experienced EM residents, unless they understand the why, right? Like if it doesn't mean something to you, you won't change your practice. So I want to start with some of the why before we get into the nitty gritty. And guys, please come on in. Hey, Seth, thank you for coming. So let's talk about the big why. Look, I think it comes to no surprise to any of us that emergency medicine truly lives at the intersection of critical care and end of life. This paper by Elmer et al. That was just published a couple years ago essentially calculated that, and it kind of surprised me. I knew we lived at the intersection. I wasn't quite sure we lived this closely at the intersection, that approximately 11% of all American deaths they happen in our emergency department. So essentially 1 out of 10 deaths in America, they're dropping on our, in our setting. In addition to that, it turns out that of the Americans that die, a third of them will present to the emergency department at least once within the month of their death, which offers us a really unique window to maybe identify this group and maybe help guide them to make sure that their trajectory is consistent with their goals and their wishes. You know, emergency medicine, again, not surprising, we were very much founded around a resuscitate first paradigm, right? Originally in the early 60s and 70s, really looking at, a setting for unplanned healthcare visits, for critical illness, sudden death. And often, I think emergency medicine physicians, we live most comfortably right within ACLS, right? Activate the code team, airway, breathing, circulation, defibrillation. Like that's our groove, that's our jam, and that's where we're most comfortable. But the reality is, as we approach 2025, the settings that we practice, please come on in, the settings that we practice in are much more complex than that. Our patients are living with more and more complex illnesses, and they're living longer and longer, which just makes our job even more complex than what was originally stated when our specialty was founded. So knowing that the first paradigm is kind of where we live, this is what it kind of looks like there to your right, right? These critically ill patients come into our ED. We don't ask a lot of questions. We activate our code rooms. We go through our ACLS. We intubate them. We press them. We start giving them blood products, antiarrhythmics. We dispo, right? We dispo to the ICU or the inpatient setting. And, these seriously ill patients who, if you probably asked us, would you be surprised if they died on this admission? We'd say no. But we admit them, and then they kind of go on through these courses where they develop multiple inpatient complications, more end organ failure, acute, surgeries for bowel infarction. They're in the ICU, and then maybe as it's very obvious, like day 6, day 7, that's when we start to have these more advanced conversations around prognostication and end of life care and goals of care. We get them onto hospice or palliative services, and they die very quickly. I think where emergency medicine is clearly moving to is more into this early primary palliative care paradigm. It's where these same critically ill patients come into our emergency department. We definitely assess, go through our ABCs, but we got to pause and we got to take a second to try to get a sense of, what was their baseline? What was their function? Who's making decisions for them? What goals? What really matters to these patients? And if what really matters to them is the resuscitate, that's where we go. But if you don't ask, you'll never know. And if you do take a moment to pause and maybe discuss goals of care, a dress code status, these two things can happen, in parallel to each other, as opposed to as dichotomous as a lot of our practices currently look. All right, I want to just transition here as a framework for discussion, and I want to open this up to my panel. But I think you guys are all very well aware, not all deaths are same. Okay, and I think it's important for this discussion that we take a moment to look at the 4 core trajectories of dying. Maybe just as a feel from this room, how many of you are already familiar with this topic or these trajectories? Okay, so maybe half of the room, love it. Maybe for others, this is a great opportunity for you to kind of like to reconceptualize what you already know. All right, sudden death, right? We know this one. This is that patient. If you look on the left, is they're functioning on the y-axis, and on the x-axis is time. At the very bottom here is death, and up here are people who are living at very high levels of functioning. The sudden death trajectory is someone really like us, going on about our days, living at high functionings, have some type of acute event, intracerebral hemorrhage, acute STEMI, we collapse, and now we present to the ED. That looks very different than what I'm going to describe here on the bottom left, the terminal illness trajectory. This is historically defined around the cancer trajectories of death. And these are patients who have very high quality of life, suddenly get a diagnosis of a cancer. They still have high quality of life, but over time, what period of time, we don't know. Over treatments and as the progression of the disease occurs, their quality of life starts to go down. And it just depends on where we catch them on the ED, where they are on their trajectory of death. The top right-hand corner is the organ failure group. This is our end-stage renal disease, congestive heart failure, COPD patients. And what you can kind of see in this pattern is that when they present to us, they decompensate. We're like a tow truck. We pull them out of the ditch, right? We bring them back up, but they never get back to their old baseline. And they keep doing this dance with us for anywhere for 5, 20, 30 visits over the course of months or years. And then the frailty trajectory is much different. This one really lives around the dementia group, but these are patients that essentially have very low baseline functioning, but maybe not a lot of multi-organ issues. They live for a long time. They come in with complicated issues. It's hard to tell where they live on their trajectory. And then I'm going to go through these slides, but here are a bunch of different examples of sudden death. I think we will all agree. Dissections, overdoses, suicides. You can imagine the families involved in this, they're not ready. They're not ready for conversations. They're not maybe not ready for prognostication discussions. The terminal illness group depends on where they are on their trajectory, how prepared they are for our discussions around trajectories and prognostication. That's the organ failure group that we talked about, and then the frailty group. All right. So using that kind of as a framework for us, I really kind of want to open it up to my panel here. And I think the first question I'm really interested from this group is, what is prognostication mean to you in your clinical practices?
I guess I'll start. I think prognostication, it's everything and nothing, right? The meaning of it is so nuanced to the patient, to the context, the disease, to me as a provider and my team and my health system. But I have to start with something. And what I really like to think of those, that little infographic or those death trajectories as a starting point, and then I choose exactly like that first bullet says, I choose a period of time and an outcome of interest to anchor myself to what the prognosis is to what I'm treating clinically. When I'm working as a researcher and trying to develop prognostic scores, I'll tell you the first two or three that I developed were anchored kind of to nothing. And I found that there people may or may not cite them. I don't know. I try not to look back at them. They were not clinically relevant scores or tools. You know, when you're a young researcher, what you have access to is like secondary data, large data, so you can build models. But the model has to be anchored to something. The probability of individual, specific person, or a specific type of people that may fall into a CHF um, or a cardiac arrest or some profile of a disease over a specific period of time to a certain outcome. And I think when you're going through prognostic literature or when you're thinking about prognostic discussions and situations, you really have to be specific about that first thing in order to not be doing a meaningless thought exercise or a meaningless publication or abstract in an academic meeting.
I would add on to that. It was a really good definition, and I'd say, as a methodologist, one thing you need to think about is that prognostication is designed for proactive decision making. So what you'll see a lot in the literature is you'll see models where we retrospectively got data and we built the model retrospectively. That's great for validation and for conceptualizing what's important in that model. But clinically, the whole point of any prognostic model or predictive model, whichever word you choose to use, is for that proactive decision making. And so whether we're making predictions in the community before they come into the emergency room, maybe we're making predictions in triage before they come back to the clinical treatment area. But the big thing with prognostication is that we want it to be proactive. We also need to consider really utilizing baseline risk. And so oftentimes we'll have relative risk models where we say, relative to this group, this is how you would do, but patients don't really care about that. What patients tend to care about is absolute risk, meaning taking into consideration my baseline risk profile, how am I going to do? And so I'll leave it there for now, but just building off what Naomi said.
And one thing we'll expand upon is the communication aspect of this. It's something that we need to know, like almost with every patient. Whenever I see a palliative care patient, part of my assessment, whether or not that information is directly conveyed to the family, is where is this patient at, and what are the things that, what is my thought about their trajectory that they're on? Because that's going to affect all the things I say to that family, even if it's not overtly communicated, or if I give them a number or a statistic, I have to know that information. If the family is needing more specifics and they're open to it, then I have the window to communicate in a very direct way if I need to.
I think the way I look at it too is as a framework. It's a framework for the clinical team in terms of what we are expecting the patient to do, but it's also a framework for the patient and the family. And I think that you really need that bridge between communication, especially for families who are not medically oriented. And I think these are great tools to be able to start that conversation, to bridge that gap, and really get everybody on the same page that way moving towards that conversation.
Sorry, I just want to add one thing. I think we'll try to use the microphone. We're not going to explicitly talk about it much here, but I think that the point that Fab brought up about these are a lot oftentimes built retrospectively, but we're trying to use them prospectively. There is a group especially as we move away from fee for service healthcare, that is using them retrospectively. our administrators, our payers, right? Like there's a lot of risk assessment that's happening. A lot of this is not the stuff we publish, but it's Vizient's, behind the scenes proprietary risk modeling and prognostic. They call it risk models instead of prognostication, but it's two sides of the same coin. But you cannot just be a bridge to your patients about understanding prognosis or with risk models. You can be a bridge to those administrators and those payers as an advocate. That's a separate discussion from today, but I think it's a really important one because it's coming. It's coming fast. Some of you guys probably already see it in our payment models and the motivations of our administrators and trying to get us to sort of drive to certain outcomes and certain things.
That's a really good point. And I'm going to transition here for us then, and I'm really interested from this group of experts, what prognostication tools are in your armamentarium? Are there certain prognostication tools that you really stand by and use regularly in your practice? And I'm kind of interested, and we put up a list of different prognostication tools. It's open to even this group's, insight on which ones they like and which ones they're using.
So I can speak to this a little bit. So some of these scores are helpful, and for example, when I see a heart failure patient, and these can't be used in isolation, but they can help guide certain things. So for example, Seattle heart failure model takes into account the lab values, the actual diuretics are on, the doses of those diuretics, and it kind of the model that kind of gives you a sense for how serious and how severe this person's heart failure is. But that doesn't include understanding of, if this patient has a cancer or if this patient has some other condition driving their prognosis. I like to tell people when this comes up, it's not it's not like a choose your own adventure where you have the whatever prognosis is the lowest is your prognosis. It's the sum total of all those things interacting with each other that affects your prognosis. So that has to be taken into account. Some of these I literally just used recently. So and this is a good example of not overtly giving that information, but using it when making decision making. Patients that we see a lot that we certainly, I think, Gestalt, most of us that have been in practice a while would say, the severe head bleed, where there's a major functional impairment, or there were already some pre-existing functional impairments. That's one where I think a lot of physicians are fairly comfortable having a pretty pointed conversation about prognosis in the ED. Just had one recently that was an older lady. She was very functional, but had early dementia. It comes in GCS3, full code as far as I know. It's innovative, large shift, IPH, right? Most of us would know just we would know that that's bad, right? But there's something called the FUNC score, which is a functional score. So essentially, that predicted like no functional outcome whatsoever, and the ICH score also predicted basically 100% mortality. Now they'll tell you don't use those scores for predicting because they don't. Sometimes what can happen is if you tell somebody what's really bad, they'll make a decision just based off that information. But the family was very clear, and this is something I think a lot of us would navigate. If this person had a major loss of function, that would be unacceptable. So that's the piece. I didn't actually talk about any of that stuff with them. I didn't give them those numbers. But what I said to them, I said, if there was some slim chance that she might survive, she's going to be incredibly impaired, and that's not likely to come back. That's what they need to hear, right? They don't need to hear the data from the scores, but I know when I'm going in, I've already looked at it. So that's going to make my conversation, even though my gestalt was already, this is pretty terrible, I have that data in the back of my mind. If they actually asked me, I could pull that out if I needed to. So I have it in my pocket if I need it, but mostly it just helps me in the conversation to communicate at the gravity of the situation in a way that they'll understand.
Right.
One thing I'll add to that is if you look at the models, oftentimes when we think about prognostic models, we think about predicting an outcome. Mortality is an outcome, readmission is an outcome, right? But sometimes, if you look at frailty, for example, we're trying to predict a process measure. And so, what do I do with frailty? Is frailty truly an outcome? Well, what do we do with frailty in the emergency room? We use it to therefore delineate who needs a comprehensive geriatric assessment or who may be at greater risk for outcomes down the road. But frailty is actually not the outcome itself. And so, really trying to reframe your thinking of prognostic models here and thinking we're not always trying to predict an outcome. Sometimes you're trying to predict a middle mediator or a process that can inform clinical decision making. Because can I predict if someone's going to be frail? Yes. But is that an outcome in and of itself? Well, what do I do with that as a clinician? If I go to an ED doctor and say that patient's frail, they're going to laugh me out of the room because what do I do with that? So just reframing your thinking that it's not always predicting an outcome. Sometimes we're trying to predict a process that will then lead to consequential outcomes down the road.
So kind of what I alluded to. Hello, there we go.
what I alluded to before. So you have to, these scores can be helpful and they can give you some tangible data that can help steer your conversation, but keep in mind you can't use them in isolation. Another score that can be helpful, we see lots of people in liver failure, right? Again, that's the MELD score can be useful for kind of getting an assessment, but that doesn't work in isolation. And sometimes you'll have a patient where you'll assess them. If you try using one of these models and you go, I think it's over predicting, right? Because your Gestalt will say, I think there's other things driving this, right? So if you have social determinants of health or people who have cancer diagnoses, they don't have access to treatment, right? They have a much shorter prognosis than somebody who's got transportation and other things. And I see that all the time. So sometimes when you have one of these things and you're like, I don't think it's lining up, if you think about the patient holistically, there's probably those things that your mind is subconsciously going, this is also driving how they're doing, not just the score that I'm getting.
And I think the other thing to keep in mind here is that it is really dependent on your location. I know our cardiologists love only the New York Heart Association classification. They don't like the Seattle classification. I don't know why. I don't know if they're just trying to keep it simple for us or for themselves. But so I think also knowing your general audience will also help you as you go through and deciding which tools to use through this process.
I like what you guys are discussing, and what I want to contrast to these prediction tools is our own gestalt. And I'm really interested on how your global gestalt, how you balance that with these prognostication tools, how you kind of combine them, because I think gestalt is as valuable sometimes as these tools.
So I think I mentioned I'm mostly ICU at this point, probably past 5 or 6 years, and Justin and I were joking about this earlier, but I'm so humbled at how difficult it can be to predict a specific outcome at a specific time. And for every case where I thought I knew what was, this MELD, NA, 90% 30-day mortality, multiple falls, frailty, everything about my prognostic scores and my gestalt says this person's not going to survive. And then, they're there back, readmitted to the ICU, albeit, but like a year later, right? It's very humbling. And so what I use my gestalt for now, having been in practice with longer term follow-up for so long, and I work in a state with like no primary care, so I am the follow-up too, is that both my gestalt and the predictive tools, I need checks and balances on both of them. I need experience. I need a case mix of 1,000 people in my mind to help me kind of really weigh what I know both from my gestalt and my clinical prediction tools, and where I think there's a large piece of medical education here that really needs to be addressed that we haven't yet in emergency medicine, in critical care, and in palliative care. I think they get at it much better, which is that gestalt takes experience, and the amount that my fellows even think that they have gestalt, and I'm like, you've seen 100 of these cases. That's not the basis for gestalt. When I look at my tenured professors, my senior mentors, I'm like, oh yeah, now you've seen this, right? I didn't get gestalt about Hanta on my 12th patient. I didn't get it on my 100th. And so I take both of them with a grain of salt.
Good point.
And the last thing we want to do in this presentation is overemphasize the importance of prediction models. I am someone who builds prediction models for a living, but the first thing we talk about in the guidelines is we don't build prediction models using math. We build prediction models using your clinical understanding. And what we find is that when you use just your clinical understanding of a patient, a context, the models tend to generalize better because the way one doctor thinks is very close to the way another doctor thinks. And naturally, we know these predictors and these prognostic factors. We've seen these patients, we know what they look like. The problem with using math to pick what goes into your model is that oftentimes we overfit a model, meaning that our model gets too specific to this specific patient or this patient population. And so sometimes it's really about balancing how accurate my model is and how generalizable it is. And sometimes we want to make sure that my model generalizes well. And so a really good example of this, one of my favorite papers is, everyone here knows the sepsis alert, I'm sure. One of the biggest prognostic models in the world. When they compared the gestalt of physicians and nurses, they did just as well, which is pretty amazing. Here's the thing though, when you're on night shift and you're exhausted and you have a trauma coming in, this is when these clinical decision support tools really help, because maybe your cognitive patterns at that moment aren't where they need to be, or maybe you're just not in that moment, you're not thinking about that patient because you have the squawk box going off and someone's coming into the trauma bay. So really, I can't emphasize enough how important your clinical experience is. It's exactly why the tripod guidelines and the grade guidelines say when you are building your models, build them with your own understanding. Don't just like use math to pick and kick variables out. You know what's important here. Once you have that baseline candidate set of predictors, then you can start playing with it and kicking it out. But build it naturally, build it with your experience because you know these patients.
Myra?
Thank you. I think another aspect of that I started including in my gestalt is the patient, him or herself. And I think, especially with what happened with Pope Francis, people are saying he literally willed himself to live. And I think that's something you have to account for in your gestalt. And there's a lot more research now showing that if a patient does have that goal, like he wanted to make it to his last Easter, he did it. Other people have just given up. And I think that's something you can't underestimate as well. And each case is individual that way.
Yeah, really taking them as an individual, and I like what you guys are discussing there. Staying along this gestalt, I just want to introduce one simple, surprise question. How many of you are familiar with this surprise question? Look, it's essentially one single question that really hones in on the clinician's gestalt. But if you ask yourself this question, I think I'm advancing. Would you be surprised if this patient died in the next 12 months? If your answer is no, then you actually have a little bit of work to do to maybe try to discuss with the patient and their family their code status, their goals of care. I think the even more powerful question for us in emergency medicine is, would you be surprised if this patient died on this admission? And if your answer is no, I'm going to be blunt here. You have an obligation now to start having these goals of care discussions, proactively get multidisciplinary palliative teams involved early. Whether the family is ready for this conversation in the ED or not is irrelevant. We can sometimes grease the wheel by starting it in the ED so that my palliative partners upstairs, they'll say, hey, you know what? Ganaga told me this wasn't going to go well. He said this as well. I think now I'm ready for this conversation. So maybe consider adding just a simple surprise question into your armamentarium. And it's a wonderful one to teach to your residents as well. But just like as Naomi said, when you're still young in your training, your gestalt is only so tight. When you're 20, 30 years into this, you don't need these decision rules, right? You've seen it, you feel it, you kind of get an instinct on it. And then to the right is actually some decision criteria that Naomi and her team had created, but we'll move past that for now. I'm really interested now, though, as we talk about prognostication tools, we talk about gestalt. Where in your practices have you guys seen both benefits of using these tools and potential harms?
Well, one thing that's really important when you think about prognosis and delivering prognosis is getting a sense for if the family's ready for it. They may need the information, but how you say it's extremely important, and also their place of receptivity to that information. One of the things that I found to be super helpful, and it's really easy, is if you have one of those patients where you're thinking to yourself, I would not be surprised if this patient died this admission or in the next couple months. When I ask the family just how are they doing, you'll have those families where they give you a very overly optimistic answer, right? They're like, oh yeah, and things aren't going well. But they'll give you an answer like, oh yeah, we've had some setbacks. He's been admitted, 5 or 6 times, but we think he's gonna get better, or whatever they say, right? I know very quickly I'm probably need to invest more time on the other, at least from that standpoint. I'm not going to get a whole lot of traction on a prognostic conversation with that family in the ED. If I have that family that has that deer in headlights look, where they have that dementia patient who's now back for like the third UTI or the third pneumonia, and you ask them how they're doing and they go, oh, it's not going good. They're falling repeatedly, all those things. That family is waiting for a physician to say, I think it's time. I think it may be time for a care transition. But just taking a temperature like that can make a big difference in knowing who needs that conversation and who's open to it. Because it's not what they say, but it's behind what's coming on behind that response.
Yeah, and I really like that, Justin, that term too, like taking a temperature, right? We do this all.
Well, so like what I have like this visual, my mathy mind, I think of those death trajectories, right? And when I'm taking the temperature, I am mapping the space between the, prognosis and uncertainty and everything aside, I roughly know the trajectory of severe dementia. And if I can map a wide gap between where the family says they are, and what I know the trajectory to be, that's one conversation. If I see that they're able to hew roughly along that trajectory, if they're understanding, they're going to use different language and frame it differently than we would, then that's a different conversation. And so he's got this slide over here. Palliative care people are not necessarily known as like polemics, right? We're not the like boys and their toys critical care ECMO guys. This is a different crowd. Yet, I will say this paper, this is like 2016, 2018, 2016, this made a huge splash in the palliative care literature. Everyone was like aghast. This paper came out. So this is a prognostic score you all probably won't use from critical care literature, predicting outcomes for people who require long-term ventilation, like more than 2 weeks or 21 days, rather, the ProVent score for what it's worth. Predicting what's going to happen to this patient who's in the ICU, trach, vented, not getting better at the 2 or 3 mile mark. So these are people who are transitioning to chronic critical illness, which a lot of people say like, "Oh my gosh, that's what I definitely don't want." Right? Like I don't want to be a vegetable. That's like this big theme for a lot of us in our goals of care. Not everyone, but a lot. So they randomized people to palliative care versus just ICU family meetings. And what was baked into the palliative care intervention was that they had to go through this Provent score, and they would give people an idea of what their Provent scores. What are you going to be alive in a year if you're chronically critically ill? And this group with the palliative care experts who, I bow at their feet. They're such talented communicators. They're wonderful. But they had to use this score. And there was a signal, a strong signal of higher PTSD in the palliative care group. Oh my gosh, this is exactly what I don't want to have happen is have more PTSD in my families who get that extra care and support of a palliative intervention. And what one big takeaway was, it was to not use prognosis, but you can't protocolize it. You can't walk into every family meeting and be like, hey, 90% chance you're going to be dead in a year, buddy. It's obviously going to go poorly, even when delivered from experts in communication. So I think of it as being incredibly powerful and a super important tool, but something you have to wield so thoughtfully with the utmost care if you don't want it to, yeah.
We're doing great. Take your time.
So that's the study.
Yeah, I can say that as I've practiced longer. The funny thing is, people when I did my palliative care fellowship, my prognostication got more optimistic because, like Naomi, I would see people that were like, this person is not going to make. I literally ran a floor code like last week, and was like, I would bet $1 million that patient didn't make it out of the hospital, and I saw that they were complaining about their breakfast after they got extubated. So hey, I mean, we'll use the term expert loosely. But the thing I can say as a very well intentioned intern, I would give very very zealous to discussions with people about what I thought their prognosis was. And Naomi's exactly right. This information can be very helpful, but use it wisely and deliver it in the right way to the people who are ready for it. And that will help. That definitely will affect decision making and affect what they want to do next. But we've all been surprised sometimes, and incorporating that into the discussion is helpful. So sometimes I used to tell people, oh, I don't think there's any way they'll survive. But I've had people that survive. So sometimes I'll say it's a very low chance. And if they did, what is it going to look like? Because that's actually most of the time what they want to know is we're not just gambling for a prognosis that's they survive and they're the same. Sometimes it's they survive, but they're chronically ill, vent dependent, whatever else it is. And that's going to affect more of the family's decision rather than just the percentage chance that they're actually going to live. It's if they did live, it's very, very slim. And if they did, this is what it would look like. That usually is a much more powerful piece of information.
And I think the important thing is to really just know your audience, and it doesn't matter how great your score is. And I think the perfect example that we come across frequently is the metastatic cancer patient who comes into the emergency department, and this person has clearly been going through chemotherapy, radiation, immunotherapy, and has not had any end of life or goals of care discussions with his or her oncologist. And as you can go in with any cancer score you want as the emergency physician, you can prognosticate this, but it's very clear that this is not the time or the place to do it. So you have to definitely keep the big picture in mind.
So like any intervention in our practice, there's always benefits and harms, and that includes our ability to prognosticate and these levels of discussion. You have a question? Feel free.
Yeah. Can you speak to the long-term effects of providing prognostication that turns out not to be accurate? Because I see this frequently.
Yes, I can. So I tend to bookend things. So I am the person in the ED, and on our team they call me like the one and done guy, because the not that sounds bad. That sounds like I practice poor medicine. I'm the because I do consults 1 day a week, so they tend to give me the care transition consults because I'm the one. This patient needs hospice. I'm like, I will get them on hospice. But I'm also in the ED. I'm seeing the ones that I'm resuscitating, and you know how all of us, when you get ready for a lecture topic, you're going to see a lot of what you're about to do in your lecture. I can't tell you guys how many patients I had just like crashing in the last 3 weeks for things. So I'm like, we're not doing this talk again, Satish. Just so you know. But one thing that's true, Alex, is I will have times as a palliative care consultant, because I kind of bookend it. I'm seeing in an ED and I'm trying to make a care transition if it's obvious they're not going to do well. And then I see them several days into hospitalization or sometimes a prolonged hospitalization. It is a lot of uphill inertia to overcome when somebody's delivered either a really poor prognosis and the patient survives, and then they don't trust anybody, or they've been given the classic one is that post arrest anoxic brain injury, and some person will say, oh, it'll be a week or two before we can prognosticate this patient. I'm like, no, it's not true. And you're just, that family will be so fixated on that time frame, it makes it very hard down the road. So I think it is helpful when you have a patient who and we're going to talk some about trials of treatment. When you have a patient where you're concerned they're not going to do well, you can be kind of general. You can say, I'm concerned about how they're doing. I'm worried I'm worried they may have a limited amount of time. Even if we try these things, we may have to see how they do. But that way you've kind of teed up the people in the hospital, whether it be the intensivist or whether it be the palliative care team later on, by not giving like an exact number, and you can give a range too. So even when I give people I'm sending home a prognosis, I'll say, you have weeks to months, but if your family member gets a pneumonia, that's out the window, right? If they get sick, they got terminal cancer and they get sick, and now we've got a new problem, that could be days. So I've kind of teed them up for this understanding that yes, we have this general idea about their disease process, but new problems change that, because otherwise they may just get fixated on the time frame you gave them. Oh, sorry.
And that was a really good question because prognostic models do make mistakes. They're made by humans. I think the one thing we need to think about though is in what direction is it making the mistake? And so where is it biasing towards the null, or is it biasing towards, so for a really good example here is if I'm trying to predict end of life mortality, right? I want my model, if it's going to make a mistake, to bias towards I'm going to assume you're going to survive. Right. And so that's something we really need to take into consideration is yes, models are going to make mistakes. One thing we don't do really good with models though is doing a good job of displaying where does this model make mistakes? How does it calibrate? But and also more importantly, where is the bias? Is it going to bias towards an outcome we want or not? Because it depends on it's all contextual. If I'm making a model to essentially delineate who needs advanced care planning discussions, then I'm going to want to overestimate mortality in that case because it's not deciding for them, but rather it's initiating the conversation. Now, if I'm actually making the same prognostic model and I'm trying to actually predict mortality or survival in the hospital and it's gearing towards the clinical interventions, then I want to assume they're going to survive. And so every model is going to be a bit different and it's always specific to the context. But what's really important to understand is that these models do make mistakes. How much of a mistake are we willing to accept? And in what direction do we want that mistake to be?
That's a really good point. We should probably
Oh, no, go ahead,
Yeah.
go ahead.
And the only reason because you guys that's a great question because it really transitions us into the next phase of this lecture, which is the tools that we have, the communication tools that we have to maybe embrace these conversations. And feel free, Naomi, to continue there and transition over. But we want to talk about a variety of communication tools that this group uses. I'm also interested in what this group uses that's effective in your clinical practices. But I'll start with you, Naomi.
Yeah, no, I think that it's an awesome question. Where you're starting with the science and the models is like, okay, if I got a model for survival of cardiac arrest and the area under the curve is like 0.75, what that is telepathically telling me is like the the breadth of uncertainty here is really wide. Whereas I've got a model with great calibration, great discrimination, area under the curve is fantastic, et cetera, et cetera. There's still uncertainty, but maybe that's smaller. So I'm going to talk to myself through, and then I've added my gestalt, et cetera. There's always uncertainty. Uncertainty is the name of the game. Be very wary of the colleague or the resident or the fellow who doesn't understand. Uncertainty is like the bottom line. Or yourself when you're feeling overly certain. I had a guy who I upgraded from the floor of the ICUs again. It was like, 2 days before I got here. And older gentleman, frail, street homeless, unhoused, COPD, right heart failure, circle of death was a DNI. So I put him on BiPAP. I start, milling on this, that, and the other thing. He's just circling, circling, circling. He's estranged from his son. And I was too certain, and I was like, I really don't think he's gonna be here till morning. I've been surprised before, so he could, but I'm really worried this could be the end. And if you have that feeling in you that you want to be by your dad's bedside, even though you're estranged, and this final moment's gonna. So he comes in. He thinks he's coming to see his dad die, and I walk in at 7 o'clock the next morning. Off BiPAP, off pressors, not even on oxygen, complaining about breakfast. And I'm like, what is happening here? So there's always that uncertainty, but it worked out with the son. Larger issues about the repair of their relationship worked out with everyone because of how I think these are two awesome tools to have. Time limited trial and best case, worst case. And if you're not familiar with them, there's really neat tutorials, especially for best case, worst case. You can just YouTube it. It's a great little whiteboard tutorial. It's Gretchen. I was about to say Gretchen Whitmer. No, Gretchen, someone from the Midwest. I think University of Wisconsin, and then time limited trials is less well out there, but a wonderful tool for ER docs to have. What they're both predicated on is alignment in a world of uncertainty. So in this world of uncertainty, I'm going to align with you that I want the best possible outcome, and that's true. And if it's not true, then you have a larger conversation to have with yourself existentially. I want that best possible outcome. But that I'm uncertain, so I'm going to follow along with you to see, are we reaching the best case? If not, let's talk about it. Are we driving towards that middle case? Is that acceptable? That's the conversation of best case, worst case. The conversation of time limited trauma, I'm hoping that this sepsis resolves with maybe just single organ failure or whatever, but that if I see in 2 to 3 days, or my ICU colleagues see, we are developing kidney failure and we have shock liver now, and there's severe encephalopathy, and I've got 1, 2, 5, 6 organ failures. That time limited trial of critical care is not producing that best case outcome, or maybe even that middle, like we're now shooting towards the bomb. And so if you guys have in your ICU or in your ER that septic patient, even the cardiac arrest patient, even the ICH patient, depending on where they are in their uncertainty and their hopes, you align there, and then you pick some tool to discuss how to manage that uncertainty as things unfold.
I love that.
I also find time limited trials really helpful. I have a toddler, and if you've ever noticed, any of those of you are parents, you'll notice like you can't take away something from a toddler. You have to give them something else to get the thing out of their hand. So we think in terms of, I've got a bunch of treatment options, and people here, we're taking stuff away. That's what they hear. They hear about us taking stuff away. And subconsciously, we're all going to just naturally fight that and say, well, you're taking my stuff away, right? Even if we're adults. So what I talk about is what we can do for people, and that deals with that psychology. So when they're failing critical care intervention, you can say, well, we can make sure they're comfortable. We can make sure we alleviate any suffering they're experiencing. We can allow for their body to just go through the natural process it would now. And for any of the death trajectories, if you've got, except for sudden death, if you've got a person who's got recurrent organ failure, like the CHF patient where you're worried this is their last go, or the advanced dementia patient that's had multiple admissions for different things, or your cancer patient who's really kind of falling off the curve. If the family recognizes there's a problem, but they're just not at that place of comfort measures. If I say, let's try these things, let's see if her UTI gets better and if her encephalopathy gets better, they are much more amenable to reducing, eliminating the possibility of like heroic measures, but still trying some things. And then if they get better, we kind of save face, because even if we were we weren't super optimistic, like they're like, yeah, they said that she might get better. She got better. We haven't destroy the prognostic abilities of others in the future to kind of help if they have that situation again. But they also have that ability to process the bad news. And then if they continue to get worse, they're like, we did try this thing. We did try this thing. It got worse. And now maybe it is time to do comfort measures. And families are just very receptive to that. And if we start that in the ED and start that conversation, it really helps our intensivist colleagues out, and it helps our palliative care colleagues out later on, regardless of what the trajectory is. And then the families can actually generally respond very well to that.
Please, Daniel.
Sorry, Laura.
Yeah.
Justin, I think you kind of shared your perspective on it just then, but I think sort of the aspirational level of doing a time limit trial includes some sort of real specific time frame, some measurable outcomes to look at over that time frame. What are our goals? And that can be challenging to do in the ER for a number of reasons, because we're not the ones admitting the patient, so ultimately we don't get to set what that time frame looks like and what those specific measurable outcomes might be. So like when I'm doing consults in the hospital, my time limit trial conversation is different than my time limit trial conversation in the ER, because I don't want to feel like I set the IC up for failure by setting some parameters for that time limit trial. And so I find that I'm often either teaching our residents or myself doing more of like the alley-oop method for a time limited trial, which I think is basically what you were saying, which is like we're gonna like vaguely talk about time limited trial, like let I'm worried some of these things might happen. And it would be helpful for the ICU to reevaluate how this is going in a few days or weeks. So I was just like curious what, especially as an
I
internist and
completely
others.
agree. ER is very hard for you to submit the ICU to, trial a CRT or whatever. But I don't think of time limit trials specifically as a health literacy tool, because I can't tell you how many people have no real conception of what you're doing when you're resuscitated or when you're using life support. They don't understand it, nor should they, right? But if you are sort of just suggesting the idea, like this is where the art is explaining the science. They're gonna try some life supports or some ICU measures. Like you can be really vague about it. They're gonna see how they respond, because then it sets the person up to understand even like, very sort of lower middle health literacy ranges, or just emotionally overwhelmed. Could be a PhD professor, but they're emotionally overwhelmed at the impending potential death of their loved one. There is a test to see if treatments will work. It's like a profound concept. Treatments may not work. Is built into that.
Yeah.
And we're gonna watch to see is built into that, rather than like they're just gonna sustain you on the bed. You're like, okay, what's next?
Yeah, and I think you are not a plant, but it is a great question because I think the issue is becoming more and more relevant to the emergency physician as boarding times increase. I know for us, I mean, we routinely have 6 to 8 ICU boarders for over a day. So I think it's something, the time limited trial is actually becoming more of an emergency department issue. And I think it's something that we definitely need to talk more about with our trainees. And I think the other thing too, going to the health literacy, it's kind of funny but pathetic at the same time. Use things like the pit. Everybody's talking about the pit. Say like they saw what happened there, and if you can relate it to something to get people to realize like this is kind of reality. And if that's the only thing you have to reach somebody on a health literacy level, you have to use that. And I think it's just something that we're going to be seeing more and more often. And unfortunately, like I said, this is becoming more of an EM issue than an only IC or only palliative.
You'll know if it works because you'll hear them call their, the whatever who's at home, and if they don't understand what's going on, they'll say, well, they're put them on the vent. But like that's not really what's happening. You're trying the vent to see if you can buy them time. But when you use a time limit trial, they'll call and say, well, they're gonna try and see how it works, and you're like, oh, they get what's going on, and we're partnered on hoping it works or hoping whatever.
Yeah, the phone call right after you tell them something, that's gold. That's so true. Because if they say, mom's not doing good, you need to get to the hospital. Yes. No, not really. Like, it's not a mic drop. People think very binary. So when they think of surgical decisions, they're like, it's cure, right? It's a fix. And they think about interventions very binary a lot of times. Like, it's a fix. Like, if the doctor does this, it fixes the thing. So I think your point about health literacy is really, really accurate. I never thought of it that way. But that's so true. It puts in a context I'll understand.
And I want to continue on this topic, but I want to talk about this model, the trauma-informed care model around conversations. Are one of you up for it?
Sure. Yeah.
Yeah.
Good. Who here is familiar? I feel like it's becoming a lot more common in Lexington. You're familiar with trauma informed care principles a little bit. Um, I think these will come in handy in like every difficult communication task that you have, including goals of care and prognostication. But essentially, like when you're having a goals of care or delivering bad news and the response seems totally outsized to what you would have expected, even in the context of terrible bad news, you're like, whoa, I did not see that coming. Probably there was an opportunity to use some universal precautions around trauma informed care. And I don't want to say, oh, you missed it, but like, or we missed, I missed it. But the idea is that people are coming to these events with a lifetime of different experiences that you may touch off without even knowing it. And creating a measure of safety, aligning, assuming that there's not trust, and trying to begin to build a trusting relationship can just be absolute gold in terms of one, your moral distress. It feels awful to have a conversation with someone and walk away with it like, oh my gosh, they sort of thought I was a terrible person and I was, harming them and I didn't intend that. Well, why did that happen to me? So there's this like moral distress level, but also I think you'll find that it's much easier to collaborate with, because I think we're really talking about family communication here more often than patient. Um, to think about these pillars of trauma informed care will allow you to get further into a conversation. Or even the model that med students use most commonly, like spikes for breaking bad news. You guys probably all were exposed to spikes or teach spikes. But it's just like that situation. Give them control over the context and the setting. Um,
No, you're great.
One thing that's helped me, and I'm married to a therapist, which I could have therapy about, and my sister's a therapist too. So, and we're talking feelings therapist, not physical therapist. The trauma piece is a real big point. People don't sprout coping mechanisms in the middle of an emergency. So when you have families that already have their own issues and situations, all that stuff just gets heightened. So if you kind of soften yourself and realize like they're coming at things. We've all had that code where we have to call the code and we're like waiting for that family member to just explode when we know that we have to do what we have to do. So just keeping in mind that the emotional toll that they're under at that moment can help you maybe not take on as much of that distress when this happens.
And then, guys, out of respect for time, it's
Yeah.
11:50. But we do, unless anyone's pushing us right out of here, we wanted to open it up to this audience for questions, comments. Really, again, years and years of experience of practicing EM in this room. Really interested on certain tricks or tips that you might want to share back with this group. Also, I wanted to, if you guys want to take a picture of this, is this like a scan and learn? A wide variety of primary palliative care resources, websites that you could consider sharing with your residents or fellows. Also wanted to share, this is, I did an Ignite a couple of years ago, like one of those slide progresses every 15 seconds, and I forgot to turn them all off here. That's why this is happening. But these two resources are wonderful as well. This one's been created by Dr. George and Dr. Auchi. But it's a 5-minute ED code status conversation guide. I actually keep this one on my computers in my ED. After a conversation, a delivering bad news or a death notification, if it doesn't go so well for my resident, I try to debrief them and I hand them this tool. It's a one pager for them to kind of guide it. If you're not comfortable with these conversations, you might find new language here that will help you along the way. And then, this last couple of things, I just want us to be all really clear. Like, primary palliative care in the ED, this isn't just the 5 of us and a group of palliative doctors talking about this. Our own college, in 2015, very clearly 2013, identified this as one of our top 3 priorities on choosing wisely. The U.S. Best Practice Guidelines for Primary Palliative Care in the ED, published just a few years ago, clearly recognizes opportunities for EDs to do some palliative screening, have goals of conversation, and consider early palliative care referrals. But then I'm just going to pause it out to the group. Any comments, questions, open to anything.